Our work plan has been identified for us and set for us by the Australian Health Ministers Conference. Under our legislation, that's who we report to, and they approve our program of work. We were established following the 2008 COAG National Partnership Agreement on Hospital and Health Workforce Reform, and that work program and that National Partnership Agreement shapes the range of work that we are to undertake. But in essence, the main challenges that were identified by COAG and reflected in the National Partnership Agreement are around 4 key areas, and our work is focused on those. The first one is getting better planning information and analysis around the health workforce. And I think Robin's comments earlier to some questions about the information available to make future decisions about the health industry and its workforce very heavily depend on having good, up-to-date planning and analysis information. The second key area is focus on the clinical education and training system and some aspects of reform. A third area is to look at health workforce reform overall. The predominant focus of our work program is on the professions, though not exclusively, and certainly when we get into a national approach to health workforce innovation and reform by necessity, it will extend well beyond the established health professions. And a final area, which I won't be covering at all today, is international recruitment. Let's first to the National Training Plan, which is a piece of work that Health Workforce Australia was asked to undertake by health ministers at their November meeting. The National Training Plan has a very laudable goal of self-sufficiency in health workforce supply by 2025, and this was a goal set by health ministers back in 2025, noting of course that we operate within a global context of labour supply. The implication there is that the health industry has a very heavy reliance on overseas trained doctors and nurses, and in some years over the last 4 to 5 years, been up to 6,000 per annum. We have been required to import to meet basic health system requirements. So the notion of self-sufficiency is not to say that we don't have a workforce that has overseas trained doctors, nurses and health professionals, but rather we should not have that degree of reliance, which indicates some issues with our training system overall. The scope is doctors, nurses and midwives, professional entry, postgraduate and through to specialist requirements. And the plan really develops 4 or 5 scenarios for the future. It goes out to 2025 and will look at the training requirements, assuming the status quo remains, but it's just overlaid by population growth and utilisation growth. But more importantly, we'll be looking at some other scenarios, and those other scenarios are really reform-based scenarios and scenarios that look at a more equitable regional distribution of the health labour force. And that in effect is the most intensive part of this work. Once those scenarios are developed, we'll have 4 or 5 views of what 2025 will look like, and then we work backwards to create a series of, through a pipeline training analysis, to have a look at a series of annual training plans that provide guidance to the higher education sector, guidance to employers, the funders of the education and training system, and also to those directly involved in resourcing and planning for clinical training in their workplace. Second key area is to focus on some of the clinical training reforms that we've been asked to undertake. The first is the introduction of a subsidy to support growth in clinical training requirements in the health and aged care sector. Its scope is 22 professions, and its scope is professional entry, and that was really set through the National Partnership Agreement. It offers a range of recurrent subsidies to support the very significant growth in health professional training that's taking place in our health, aged and community care sectors. We've completed funding round offers, and this funding subsidy will help to support a 9% increase in the overall baseline of health professional students in training over the next 3 years, and approximately a projected 30% increase in clinical placement days. and we're now in the process of many of the contracts have been signed and the funding begins to flow from this month. We've also recognised, and this is again reflecting the COAG National Partnership Agreement, that the quality of supervision in the clinical training environment is absolutely critical, and most clinical supervision takes place by people who are passionate about teaching and training. Some of them have made a career out of it, but generally speaking, those involved in an intensive way in the training of health professionals are not necessarily the most highly paid group within those professions. So this program recognises the need to build up their skills, develop a national core competency framework for supervision, focus on the consistency in approaches. Many organisations have to deal with students from up to 12 or 13 universities wanting to receive placements in those settings, and that's often very, very confusing if there are 12 or 13 different ways of assessing and supervising a health professional in training. So this is some nuts and bolts work to get a bit of standardisation. And the final piece of work that I'd like to just briefly outline for you is a significant national policy and strategy piece, which is the National Strategy for Health Workforce Reform and Innovation. It seeks to develop an agreed framework for action by government, by industry and by higher education providers and those involved in training, particularly with a focus on the flexibility, the efficiency, the productivity and the responsiveness of our health professional workforce. There are approximately 30 recognised health professional groups that are operating throughout the system, plus a large range of assistant workforce categories. And typically reform happens at a local level, at a regional level, and it's usually in response to specific local circumstances. So part of this piece of work is to create support for broader national adoption of local reforms, but it's also to provide a framework for decision making, because anybody who's involved in reforming the health workforce would understand that it's not an easy pathway. The work can be very hard, and before you invest the time and the effort and sometimes the political skin that's required in engaging in solid health workforce reform, you need to make sure that the investment is going to be worthwhile and that the gains that you will make will be realised in terms of better quality care for patients and clients, a more productive workforce and improved accessibility, because there are certainly many reform efforts that don't really pass those tests, yet are still occupying the efforts of the industry and government overall. So this strategy piece is to seek Health Minister's agreement on a framework for progressing reform on a national basis and for supporting local and regional innovation and reforms. It has 5 domains, and in many ways they're very reflective of some of the categories in the environmental scan, but they recognise micro workforce reform at the workplace, a focus on capacity and skills development, the need for leadership to drive and support change, better quality workforce planning, and of course, whenever you progress reform, particularly in a regulated workforce such as the health industry, there needs to be a responsiveness in terms of policy, funding and regulatory responses when roles, responsibilities of workers are changed and when scopes of practice are broadened. This piece of work is ready for national consultation, and most of you, in fact I'm sure that all of the groups here will be given the opportunity to work closely with us over the next couple of months to get your views and your input into this important piece of work. So I'll conclude my presentation with that, and thank you very much for inviting me and for your patience in listening today.